of all, I want to thank you all for joining us on a Friday afternoon. My name is Lizzie Pulgarone, for those that I do not know. And I also wanted to share, I had a few technical glitches just before joining, so I appreciate your patience. And I see this little internet unstable. So if I switch to my phone halfway, please bear with me. Or if I can't connect, Roger, just go ahead and get started because I don't want to hold this up. The timing of mandated updates and all. But we're really excited from the Promoting Behavioral Health IPC, both Julieta and myself and all of our members, to have Dr. Harrison joining us today for our grand rounds as our invited speaker. I'll tell you just a little bit about Dr. Harrison. There is much more to share, and we can share via email or look up in some way, but really he is a gem of a person, and I'm so honored to have you with us today, Roger. So more formally, Dr. Harrison is a pediatric psychologist at Nemours Children's Health in Wilmington, Delaware, and also a clinical associate professor of pediatrics at Thomas Jefferson University. He received his PhD in clinical psychology and has been working at Nemours for various years now, and that's where him and I initially met. What feels like not so long ago, but maybe it's been a minute, let's be honest. Really interestingly, Dr. Harrison is the co-founder and co-chair of the DREAM IPC conference. This is a national biennial conference in Wilmington, Delaware, that focuses on pediatric integrated primary care. I highly recommend that you all consider attending. I've really enjoyed that conference. And it's very unique and has a great group that comes consistently. In addition to his work at Nemours and the conference, Dr. Harrison of course, conducts clinical work, both psychological testing, as well as working through the Parent-Child Behavioral Clinic and other clinics at Nemours. Previously, he served as the chair of the Delaware Psychological Association Diversity Committee and currently is president of DPA. Congratulations on that. Dr. Harrison serves in other leadership roles and has received various awards in the community. He serves as on the Social Determinants of Education Work Group, as well as a task force to guide policies and practices to achieve educational equity in Wilmington and northern Newcastle County, Delaware. Some of the awards that Dr. Harrison has received include the 2023 Association of Psychologists and Academic Health Centers, John Robinson Distinguished Contributions in Diversity, Equity, and Inclusion, and the 2021-2022 Association of Postdoctoral and Internship Centers, or APIC, Biennial Award for Excellence in Diversity Training. Maybe most importantly, I will share that Dr. Harrison is also happily married to Ayana and has 3 remarkable daughters who he shares his time with when not busy in all of these other things that I've talked about. So with all of that, I ask you to help me in welcoming Dr. Harrison, and we look forward to everything you have to share today.
Thank you, Lizzie. Dr. Pulgarone, it's a pleasure to always share space with you at any time. Having previously shared space together at said institution at Nemours. And thank you for inviting me here. For everyone who's here, we're going to spend some time today going through an overview of this training model in cultural humility. This was not developed on my own. It was developed in conjunction with my colleague, Dr. Cullinan, who currently is at the University of California, San Francisco, or UCSF. But I am here alone, and hopefully that's acceptable. I don't have a slide that says I don't have any disclosures, with the exception of the fact that I do work for an institution and they pay me. They do not pay me to do this work. This work was developed on my own time. I have no other anything else to disclose. And I'm going to jump right into it because we're going to be here a while. We're going to be here an hour, but we're going to be covering quite a bit in this hour. We're not going to cover this. What you're looking at is an overview of our entire model, and we've been working on this model now for the past 8 or 9 years. It is an experiential model in its full practice, and it is very much steeped in intersectional theory, where we're considering all of the ways that our identities come together to impact the experiences that we have within the healthcare system and also within the world at large. And I also want to add that this is explicitly an anti-racist model. meaning we recognize that it's not sufficient for us to simply be good people and hope that everyone else around us is a good person, but we must take explicit action both personally and institutionally if we want to meaningfully reduce the impact of racism in all of its forms. And so you are looking there, and I'm going to just jump in. And one of the things that I'm going to do is I'm going to turn up the pace of my speech just a little bit to this pace because there's so much that I'd like to get through with the time that we have. But let's start by why now? Well, why do we develop this? Uh, Everyone around can see what this graph intends to display, that America is changing. And so, regardless of the discipline that you were trained in, be it medicine, social work, psychology, speech language, um, the people who trained you and the people who trained them probably don't look like the face of Americans' youth today. We know that projected out, we're going to see significant decrease in the number of Americans who are white identified. In fact, during the last decade, numerically, this is a graph from the Metropolitan Policy Program at Brookings that shows that white identified Americans are the only demographic who have numerically decreased and the only demographic projecting forward who will have a numerical decrease in their numbers in America. Uh, when we think about young folks, we know that the most significant increase will actually be those who identify as two or more races. So biracial and multiracial people are going to constitute the majority of America's youth. You happen to live in a state where um, non-white people under 18 are already the majority of the youth population. And so this is not going to be any surprise to you, but things in America are changing. This slide is really busy. Forgive me. This comes from the N.A.E. Casey Foundation. And if you could see my mouse move, this is just a chart that says the same thing again, which is the states that are having the biggest numerical increase would be Texas, Florida, and the state of Washington. That Now, when we look at all children of color, which states are going to have the largest numerical increase in children of color? Those would be the states of Texas, Florida, and Washington. And then if we go down here for Hispanic or Latino, any race, which states are going to see the biggest increase in Hispanic or Latino young people? Those would be the states of Florida, Texas, and New Jersey. So Florida is changing, America is changing, but we have a few issues. What I'm showing you on the screen, for those of you who are unfamiliar, would be considered the Heckler Report. This was published in 1985 by Peggy Heckler, Secretary of State. And this was the first time that the federal government had taken an entire countrywide look at the state of health disparities, intentionally looking at the experiences of those people who are white identified and those people who are not white identified. And so in 1985, this is just the cover, but Peggy Heckler says this. She says, hey, America, we're doing great. Americans are living longer. We are healthier, but, and that but says, and it's underlined, there was a continued disparity in the burden of death and illness experienced by Black and other minority Americans as compared with our nation's population as a whole. And that disparity has existed ever since accurate federal record keeping began. And yes, prior to 1985, we had institutions, we had universities, we had foundations who were collecting this kind of information on health disparities, but the United States federal government had not undertaken the process of looking at the state of health disparities across the entire country. And so Peggy Heckler ends a report that says, hey, now that we are aware of these disparities, now that we notice that those who are non-white, if you look here, you can't see it. It's referring to people who are Black, Native American, Latino, Hispanic, and Asian Pacific Islanders. Now that we see that there is this significant disparity in who bears the burden of illness and disease and early death, this knowledge no, it should mark the end of the beginning of the health disparity that has for so long cast a shadow on the otherwise splendid American track record of ever improving health. And what I'm not showing you is that at the time, the Department of Health and Human Services created a 5-year plan to eliminate the disparities that were identified in the Heckler Report published 1985. Now, can someone make a guess for me? By 1990, would you guess that we had resolved those disparities in health that have sullied the otherwise splendid American record? No, no, you don't have to guess. In fact, fast forward to 2022, in 1999, the Congress passed a law and created AHRQ, the Agency for Healthcare Research and Quality. And every year since 2003, AHRQ has published a National Healthcare Quality and Disparities Report. You can go to ahrq.gov and you'll find that report there for all of the years beginning in 2003. Every year, the report essentially reads the same way. And the report starts by saying, hey, America, we are doing great. Americans are living longer, we're healthier, more people have access to healthcare, but we notice that people who do not hold white identity continue to disproportionately bear the burden of disease and illness. They die at younger age, and they die from every single cause at a disproportionate rate relative to people who are identified as white in every single system of our bodies. The one difference that I want to highlight from the 22 report that you will not see going back to the 23 report is that they highlight some key findings. And the key finding that they says that we saw here in the 22 report is that, for the first time, we want to report that life expectancy has decreased. And we're using the data that we have, which was 2020 data, and that was largely due to COVID-19. And that decline in life expectancy was greater for Hispanic Latino groups and for non-Hispanic Blacks than for non-Hispanic whites, thus widening a health disparity among these groups. And so part of the impetus for doing this work is that we continue to see year after year, and they track hundreds of different metrics. And this is another busy chart, but I want to summarize what this chart is showing you. Again, this is coming from that 22 report. And this is saying, hey, people who want an appointment just for routine care, what do we know about the disparities? And if you follow my mouse, what this is saying is that the disparities for just getting an appointment to see a healthcare provider has worsened for every single group relative to the reference. In other words, for everyone who is not white, it's become harder to get an appointment. For everyone who is not non-Hispanic, it has become more difficult to just get an appointment. For everyone who is not middle income or higher, it's become more difficult to get an appointment. For everyone who doesn't carry private insurance, it's become more difficult to simply get a healthcare appointment. And for everyone who doesn't live in some kind of large metro area, in other words, like the city or the suburbs of a major city, it has become more difficult to even get an appointment. And what you're looking at is the first table in the appendix. So table 1 verse 1. They have hundreds of tables. The first table says, you want an appointment for a doctor? It's probably better to be non-Hispanic, white, middle class, and upper class with private insurance, living in the suburbs or a large metropolitan city. And if that's not you, the disparities have worsened. Here's another chart Looking at the hundreds of metrics that they look at to gauge healthcare quality from AHRQ, they track what is this empty line is going to be a baseline, and this solid line is going to be a current. And what this is saying, for those Asian identified, their health overall kind of health outcomes tend to be strong and slightly improving relative to baseline. For non-Hispanic whites, we're making really good progress in terms of the quality of health that they receive and their health outcomes. But for those who are Latino Hispanic, they've been average, and we're seeing a slight decline. And for those who are non-Hispanic Black, they've been bordering weak, but we're seeing a non-decline. And why does this matter? To me, this matters because the difference between having strong healthcare and average to weak healthcare is a difference about whether your mother lives or dies, whether your grandparent emerges from surgery alive or dead, whether your spouse emerges from childbirth living or dead. So these differences are not just statistical and numerical differences. These are differences that have really meaningful consequence for the families and the communities that we serve. And so we created this training for healthcare professionals, realizing that I cannot sit back and work my entire career reading another report every year that says, hey, America, we're doing better. The only thing that we notice is that if you're not a non-Hispanic white person with private insurance in the middle class living in the city or in the suburbs, those disparities continue to linger, and you are bearing disproportionately illness, disease, and death. And so to understand cultural humility, we must start with culture. And what is culture? The way I define it is that culture is everything. It's the beliefs that we share, it's the behaviors, the norms that holds us together. It's how we greet each other, it's what we believe, it's what we wear, it's how we wear it, it's how we speak, it's how we marry, but culture defines even more. It's what we believe is right or wrong. It's how we sit at the table. It's how we greet visitors when they come into our home. It's how we behave with our loved ones. Culture is everything, and culture is everywhere. And within an institution, you might have a culture that is just for your work group, and then a culture that is for the larger department that you're in, and then another institution, culture within the institution, and a culture within your state. So culture is everything. So to understand cultural humility, we have to start with this idea that culture is everything. And then there are terms related to culture, like cultural awareness. And all of these terms are important. Cultural awareness refers to any of those activities that I'm taking, whether they're didactic learning opportunities, I'm reading, I'm watching, I'm listening, to help me become aware of those differences that could be attributed to culture. Cultural sensitivity would be any of those activities that I engage in once I'm aware of the power of culture, that helps me to be more sensitive to differences in culture. But I want to shift over to talk about cultural competence, and you have two definitions on your screen. One from the American Psychological Association, being an ability or a skill, and this is how I can understand, appreciate, and interact with people who are from cultures or belief systems that are different from mine. And cultural competence involves acquiring, integrating, and applying those awareness skills, those knowledge skills, and those attitudes. But cultural humility is not quite the same as cultural competence. Because cultural humility isn't about learning about the other, it's about reflecting and critiquing on the self and my role. And so Melanie Tervalon and Murray Garcia first defined this in 1998 as the lifelong process of self-reflection, self-critique, assessing those power imbalances, and thinking how we move away from patriarchal systems of care to mutually respectful relationships and partnerships. And so to operate from a framework of cultural humility requires me to be on a lifelong journey of learning from others, not just about others, critically examining what do I know and what do I not know, increasing my interpersonal respect, thinking about how to develop partnerships that address power imbalances, and really taking this as an other oriented stance where I'm open to new information. And so the dimensions of cultural humility are exactly what you're seeing now. How do I learn and critically self reflect? How do I partner to challenge and undo power imbalances? And how can I hold institutions accountable so that we don't continue to produce these disparate, unequal outcomes? And part of that awareness, uh, when we do these trainings, there are lots of questions. Will I become culturally competent if I go to grand rounds or if I go through this training? No, you don't become culturally competent by listening to someone talk. Competence involves effort. Uh, do I feel uncomfortable working towards cultural humility? Absolutely. It can be really uncomfortable to explore those aspects of myself, including how does bias inform the care that I provide? Do we ever have time? We never have time in our systems to do any of this work. Look at your schedule and what you have. Do we develop new clinical skills? No. Again, cultural humility is not about developing skill. Skill is the thing that comes with repeated correct practice. And so once I develop some insight, I can ask myself, can I participate in meaningful activities that advance my own long-term life goals of exploring my identity, reflecting on how I hold privilege and power, considering the way that my own identity might affect patient engagement, team engagement, and how do I motivate myself to build that competence that comes from repeated practice? Well, that is the kind of thing that we're setting out to do in this curriculum that we've built. And I also just want to share that when I do this work, and I've been honored to do this work in a number of hospitals, I am very well aware that when I enter a room, there is going to be a spectrum of engagement. On one end, the left end, there are going to be those who walk into this room, and some of them hold power, who are like, why are we doing this? They're opposed. They come in with a lot of judgment, but not curiosity. We don't need to do this in our system. There's other important things for us to do. People come in, they're closed, and we go all the way over. In the middle, we have those who are indifferent, but we go over to those who are more active engagers. Those who are like, yes, we should do this all the time. We need to do this every week. Those, when we enter spaces like this, there are people who are so excited that they never stop sharing. They want to convince everyone that we need more and more of this. And it turns out that both the active resistors and the active engagers run a risk, because if I'm an active engager, I run a risk when I enter this kind of space that my wokeness, as it were, might alienate people. It might make those who are not at my level of enlightenment not want to speak. And sometimes my excitement might cause me to take up so much of the space that it doesn't allow other people to practice skills of stretching their jaws or reflecting, or strengthening their voice to be an advocate in systems that produce unequal or inequitable outcomes. So when we do this work, there are some assumptions that I go into this work with. Um, this is for those who are here to learn and grow, because I always enter the space as someone who will learn, who is here to learn and who is here to grow. I never enter the space as someone who comes to do harm, and I presume that no one else here comes to do harm. I come here assuming that all of us make mistakes because we're imperfect and I am imperfect. I also assume that we can extend grace when mistakes are made, when people misspeak. And so when I do this work, and we also have some expectations, the expectations that I set is to be self-compassionate, recognizing that we're all on a growth journey, to be curious, to be humble. I recognize when I present to teams in the healthcare system that some people look at me like the RCA dog, for those who remember the RCA dog. Like, what is that word? And I'm like, it's humble. And they look at me like, I don't, what, it doesn't compute. What does it mean? And I'm like, oh, there was no point in your medical training or your training as a psychologist or a social worker where we took a class on humility and it shows. Being brave has to do with the way that I exercise vulnerability to be willing to share of myself in spaces where I'm not sure how I'm going to be received. And then in order to do this work, it also requires uh, to be present. I know that many times when I'm doing grand rounds, I turn my camera off and I open Epic and I try to make sure that I can close notes because I've got a timeline and I get messages about delayed notes, and it's really hard to do this work when you're not present. So the training model that we created this initially with our psychology residents because we recognize that in our field of pediatric psychology, and we're not unlike other fields, about 80 to 85% of those practitioners in our field share one um, demographic identity, but it's not what America looks like. And so I'm really clear that you can be the most competent practitioner, the most competent healthcare professional. If you are not culturally competent, you are not competent. Because I cannot distinguish or separate uh, the development of clinical skill from the development of cultural skill. If you are not culturally competent, you are not competent because you end up being competent for some, but not for others. And so we spent about 20 hours over the course of a training year with our psychology residents and about 12 hours over the course of the training year with the postdoctoral fellows going through the curriculum that I showed you at the outset. And I figured that I would leave about a half an hour for us to have an example of what it is that we're doing. And so we're going to go in. Now, having set up some expectations, uh, I'm going to engage you. And that you will, I'm hoping that you will be gracious to just maybe go along with some of these asks that I'm going to be making on you. Uh, when we think about who we are first by thinking about the roles that we occupy in our lives, and a role could be anything, the position, behaviors, you know what your roles are. And so I'm going to encourage you to use the chat. Think of your life, not just when you show up at work, but can you think about 3 or 4 roles that you occupy that you can think of and you can use modifiers and you're like, what are modifiers? Well, here are a few of my roles. And while I'm sharing this, will you please use the chat? I'm going to open it so I can see what you are doing in the chat while I share some of my roles. So I'm a father. That's one of my roles. I have 3 daughters. Lizzie mentioned that. Um, I'm a husband. Got 24 years in that role. Uh, I'm a terrible friend. I happen to have friends from my childhood. Um, but it's not because of my effort. I have a core group of friends who reach out to me. They check in on me. Sometimes they reach out to invite me places. They want me to get together with them. But I'm not good. I'm not good at texting. I'm not good at calling. I'm not good at the follow up. And so I'm a terrible friend, but I also view myself as a grateful friend that I have friends who have not abandoned me. I'm a brother to 4 siblings. I'm a distant son. I also view myself as someone neglectful. When my father retired, he moved back to Jamaica, where I was born, and where he currently lives. And the siblings do a much better job of reaching out to him than I do. You know, I do his taxes and some other kinds of things, but I'm not going to be the one who regularly reaches out. And I see the roles coming in. I'm an uncle, one of my favorite roles, because it also has a part to do with me being a cousin. One of my favorite roles. I'm a psychologist. I view myself as an educator, as a learner, as a citizen. I am involved in faith practice as a church leader, and I don't mean an ecclesiastical leader. I mean like an administrative leader, someone who runs meetings, and make sure that things are happening when they should, et cetera, and look over budgets. I'm not like a ecclesiastical faith leader, not that type. And I also think of myself in the role as an advocate, someone who recognizes that I have the privilege of being in spaces where I get to use my voice. And I love that I'm seeing mom, wife, sister, friend, social worker, reader, consultant, autism parent, ally, supervisor, friend, educational leader, voracious reader, researcher, advocate, cousin, widower, consultant, citizen, uncle, brother, caretaker. I love it. I love it. Thank you so much for those who've chosen. And why do I start here? I start here because all of us have these roles that for many of us are valuable. And some of them, we don't really want to be in them, but here we are. And these are roles that we just have to, accept because, that is where we are. And then I think about every day, every day, someone walks into the healthcare system every single day to have an interaction with a healthcare provider. And that healthcare provider looks at this person and immediately discounts them, immediately decides in their mind that they're not worth all of their time and all of their effort, immediately decides that they don't have too much time to sit in the room and listen carefully to this person. And it's not because of the roles that they occupy. It's not because they're a mother. It's not because they're a caretaker. It's not because they're a coach. It's not because they're a leader. It's not because they're a friend. It's not because they're an ally. It's because that healthcare provider looked at that person and there was something about their identity that caused a healthcare provider to discount them. The healthcare provider might have looked at that person and decided that, you know what, you live in a larger body, and I don't think that you care about yourself, so I'm not going to spend a lot of time with you. They might look at that person and decide, you know what, you're a single mother with 4 children and you're coming in here with Medicaid insurance, and I'm not going to give you the attention that I'm going to give to someone who's a married parent who lives in the suburbs, who drove a Land Rover, Range Rover, parked that in the parking lot. They're going to get my attention differently. And so, won't you just think about how we hold really roles that are really important to us, and our patients are the same. They hold roles that are really important to them and their family. And when they come into the healthcare system, they don't all get treated with equal humanity, despite the roles that they hold. And that has everything to do with our cultural identities. And so when we think about cultural identities, for the work that we do, we've been using a modified version of Pam Hayes's addressing framework. And the addressing framework is an acronym. If you're looking down, you'll see that it says ADDRESSING. And we've modified Pam Hayes's work to include 2 other identifiers for really important reasons. Every single one of us holds identity in all of these areas. Some of these identities are visible to the world. Some of these identities are not visible to the world. Some of these identities carry lots of pride for us in the way that we hold them. And some of these identities we're not super proud of, but we hold them anyway. But all of us hold identity in every single aspect of this. The reason we chose to add political affiliation to our model as we work with different groups is that we're hearing from social scientists that political affiliation has become a supra identity in American culture. And that means that when Americans are asked, what they're starting to say is, uh, my politics are more important to me than any of my other identities. And now we have dating sites for liberals and for conservatives. Pew has been polling Americans for multiple years. They've been asking them questions, and beginning in the 1970s, they asked Americans this question: would you be comfortable with your child marrying someone of the opposite race? And in 2023, the findings suggested that only 4% of Americans reported that they would be uncomfortable with their child marrying someone of the opposite race. That is the lowest that they've ever seen that question poll for Americans, they've also been asking since the 1980s, would you be comfortable with your child marrying someone of the opposite political affiliation? Guess what's going on with those trends? Complete opposite. Those trends are increasing. Americans are saying, actually, I don't care whether my child marries someone who's Black, white, Latino, Asian, but I tell you what, I care if they marry a liberal. And so that matters and matters in multiple ways. And we received a lot of feedback right at the outset that we must highlight the importance of just the body, the appearance that we live in. And on the screen, you'll see that it says, the word says fat. And for some people, that word is highly activated or may even be offensive. And you might be asking, why would you put that word and not some other word? And we were intentional to use the word fat. And that is a way of honoring those activists within the fat acceptance community who are working to combat anti-fat bias and who choose to use the word to describe the experience of those who live in larger bodies. And so, even though it's an activated word, we're intentionally using that word because I know that as someone who does not live in a larger body, I have a really different experience in the world. When I go into my cafeteria, I can order myself a burger and I could order all of the toppings, like put everything on it. I stopped eating meat a few years ago. So these days the toppings are, just like the green things, whatever. But I still like, I will slather my burger with all the other things. And it's usually like a Beyond or Impossible burger. But I load it up with everything and all the condiments. And when I sit to enjoy my fully loaded burger, I never look around, wondering if anyone's looking at me eating, feeling disgusted that I'm engaging in a human activity, thinking that I'm a pig, thinking that I'm lazy. I recognize that I live in the kind of body that really shapes the experiences that I have in this world because I don't live in a larger body. And we also recognize that on every single continent of our globe, there's a relative privilege to being lighter skinned relative to those who are darker skinned. And so you pick a continent, on every single continent, human beings spend billions of dollars on products intended to lighten their skin because of this powerful idea that lighter skin is more beautiful and darker skin is uglier. And we all hold identity in every one of these areas, even if the identities aren't important to me in this very moment. And it would be almost insulting to reduce me to one of these things because of the power of the intersections of my identities. And I couldn't ask you to reduce yourself to one thing. I'd be insulted if someone asked me to do that. So, having said that, I'm going to ask you to do just that. If you were to say, man, the one of these things that kind of most saliently captures who I am as a person in the world today, I'm all of them. And this is a thought activity. The one thing, now use the actual label, don't use the category label. In other words, don't say acquired disability, just say deaf. Don't say sexual orientation, say straight. So if you were to use the chat, and this is hard because how could someone reduce you to one thing? So I'm going to do it. I use the chat. And I'll tell you why. For me, the one thing is man, for a couple of reasons. I recognize, if you didn't see, I put man in the chat. And that is just a shorthand way of saying I'm a cisgender male. Um, recognize that I'm also a pediatric psychologist, and so I work in a field where over 80% of my colleagues don't hold that same identity. Almost everyone that I supervise or train doesn't hold that identity. My boss, my boss's boss, their boss's boss, our bosses are all women. I have three daughters. I have one wife. I have one dog, and she's a girl. All around me are people who don't hold my identity, and I have to be thoughtful and mindful about what it is to function in the world that I'm functioning. As a man, to function as a clinician in a primary care clinic, where I'm working with boys and girls, teenagers, and young children. I have to be really mindful of what that means for me. But I also put man because the kind of man that I am is not just any man. It is, I recognize that for me to be here, men who are like me, men who hold my identity, have had water hoses turned on them, have dogs set on them, have been hung from trees, have been falsely accused and imprisoned, all because they have fought to be simply recognized as human. Because I'm not just a man, I happen to be a Black man. And those identities center all of the other aspects of my identity. And this is the idea of our intersection. It's one thing to say that I'm a man, but if I were to say I'm a wheelchair rider who is a man, that idea that would generate in your mind that schema about a man would shift drastically because to hold intersected identity is to recognize that even in the healthcare system, um, my experience and the experience of Black women, even though we're both Black, is not the same. And so my experience in a patriarchal system of whether or not I get listened to versus someone who holds my skin tone, but is not a man, but is a woman, these are really different experiences. And so I'm also mindful that there are powerful sexist and misogynist um, biases that don't harm me because I hold male identity, even as I deal with racist systems. And that is the idea of intersectionality. And I just want you to reflect on um, how hard was that? How hard was that to reduce yourself to one identity? When I do this work, there are people who are truly offended that I would ask them to do that because of the richness of our identity, because how all of these intersections really define who I am. Well, the reason I start with this activity is for the same reason I just explained. Every single day, someone walks into the healthcare system and they hold rich intersected identities, but a healthcare provider looks at them and reduces them to a thing: immigrant, undocumented, fat, Black, single. And I want you to think about the experience that you're having as we're doing a mental activity, as I'm simply asking you to reflect on what it would be like to even identify which one feels more salient to you. And then think about the experiences of those who enter the healthcare system, walking out of the healthcare system feeling like no one saw me in my full humanity. That healthcare provider that I spent with, they didn't see me as fully human. And that not viewing other humans as fully human, appreciating the richness of their intersected identities, and appreciating the richness of the context in which they live, the roles that they occupy in their lives, is one of the things that unconsciously drive the biases that lead to the health disparities that get reported out every year, year over year over year. You can't treat someone you can't truly see. Absolutely. And so I'm watching where we are, recognizing that those intersected identities lead to overlapping systems of advantage and disadvantage, access and discrimination. And so I could ask you, I don't know, some of you might still be feeling uncomfortable, so go for it. If you're comfortable using the chat, I'm going to ask you to use the chat, and then um, will you write 3 to 4? If you do 5, listen, I'm not, no, no one's being punished here. All right. Uh, hold on. 3 to 4 or 5. What are some of the things that, if you were saying as a culturally identified being, these are some of the, and I would, that's what I would do if I were to do that. I'm a tall, Black Jamaican man. Um, all of these matter in my life. And you're like, well, is tall there? Yeah, it is. It's actually an appearance signifier. And it matters for me. It matters for me when I go into the supermarket because someone, often an older person, will come up to me and say, hey, young man, would you mind reaching that thing? Because at 6'3", it allows me to be able to say, sure, I don't mind reaching the toilet paper on the top shelf for you. I recognize that at 4'11" or 5, even it's going to be harder for you. So that matters for who I am. It's also a very visible aspect of my identity. And when you logged in today, um, is there any one of you who did not notice that I was a Black man? Any one of you not notice that? I'm going to assume no. I'm going to assume no because even though we have been socialized or trained to be colorblind and often culture blind, to be colorblind is to ensure that we will never resolve the disparities in healthcare outcomes that could be attributed to culture or racial ethnic identities. And so thinking about who you are and watching where we are in time, um, we also go through activities that center um, cultural perspective taking, because I put in the chat I'm a tall Black Jamaican man who's a Christian, and that's also important to me, uh, just because faith practice kind of anchors the way that I operate in the world, and like lots of folks, but not healthcare professionals. On average, healthcare professionals tend not to identify with a religious or faith practice, and some of that is regional. But healthcare professionals are much more likely than the general population to not hold religious or faith identity. So I want you to reflect on, when you walk into the room, what is it that a patient, a caregiver, or even a new colleague, if you're joining a team, sees or assumes about you when you first meet them? And just reflect on that. Whatever you put in the chat, what is it that someone sees or assumes about you? For me, when I walk into the waiting room or when I turn on my camera for a virtual visit, um, I know that someone's going to see a Black man. If it's the waiting room, they'll see that I'm tall because kids look up at me and they say, "Oh, you're tall." Um, and that cultural perspective matters because when someone sees me, it activates a schema in their mind, and that schema is going to contain ideas about people like me, and that identity that is perceived. And see, the perception is what matters because I have no control over the perception. But I do know that that perception uh, can create a barrier. I know that perception can create a barrier that can be a rapport barrier. I'm having a hard time feeling comfortable working with you. I know that perception of who I am can create a disclosure barrier. I don't think there's some things I'm going to tell you because when I saw you for the first time, I made some assumptions about you. So I'm not going to tell you who's documented in our home. You look like the kind of person who's going to call immigration on me. I'm not going to tell you about some of the alternative practices that we use in healthcare, some of the natural and complementary supplements that we are using, because you look like the kind of person who's going to be really judgmental. And so I'm not going to tell you about things I'm giving my child that actually impacts the care that you're providing. When I go into a room, I work in primary care and I do warm handoffs. Um, there are many times when I walk into a room where a patient has just disclosed sexual abuse to their primary care doctor who says, you know what, we have psychologists in the clinic and I want you to meet one of our psychologists. And so imagine me, tall black man, walking into a room with a 15-year-old girl who's just disclosed to her female pediatrician her history of sexual abuse. And I'm who walks into the room. I recognize that my identity, no matter how I think that it doesn't matter, is likely to matter to this patient. And pretending that my identity doesn't impact the care that I provide makes me less culturally competent. I'm not pretending like my identity doesn't matter. And so when I walk into the room, when I recognize that I have a responsibility as a healthcare provider to create and use language that can be used to try to reduce the barrier that might be an interactional barrier, that might be a rapport barrier, that might be a disclosure barrier, or might be an engagement barrier. I don't want to keep working with you. So when I walk into the room, I say to my adolescent girls, hey, did you notice that I'm a guy? And the answer is usually, yeah, I kind of noticed. And what that does, that is language that I use to engage a conversation that will sound something like this. So the thing is, I'm a psychologist, I'm a therapist, and I'm a man. And I work with all kinds of genders. I work with boys, I work with girls, I work with cis people, I work with non binary and trans people. But even though I work with everyone, not everyone feels comfortable working with people like me. And so I use language to engage my patient in a conversation to say, hey, listen, you do not have to tell me this now because I want you to take some time and think about it. For some girls, really all they want is someone who listens to them and can help them. But for some, it matters who their therapist is. And for you, it might not matter, but it might matter. So I want you to take some time and I want you to think about it. And if it matters, then I happen to be the only one like me here in this clinic. Everyone else is a girl, and I can make sure that you get connected if it matters to you. Because what I'm not going to do, I'm not going to leave it to this 15-year-old girl. We don't hold the same amount of power. Part of cultural humility is to always be thinking about who holds power in the interaction. And because I hold the power, I cannot leave it to my patient to say, you know what? Uh, I'm not really feeling comfortable because of what I need to do in therapy. I don't think that I could do this with a guy. I think I'd be more comfortable doing this with a woman. I'm not. I could leave it, but what's more likely to happen is that patient is going to smile and nod with me, walk out because I told them to make an appointment, and they will not make an appointment, and they will not be seen again because I didn't think it important enough to acknowledge that my identity matters. And I want to be really clear about this. There is no identity or identities that you hold that disqualifies you from working with any other human being. None of your identities disqualify you, but not thinking intentionally or being mindful about the power of your identity might disqualify you from working with a lot of people. And so it becomes important that we can use language to reduce those barriers. How do I reduce barriers? Well, I ask questions. Tell me about your experiences in the healthcare system. Have you felt listened to? Have you felt cared for? Have you felt discriminated against? Have you had negative experience with doctors, with therapists, with speech therapists, social workers that you'd like to tell me about? And I'm going to tell you that there are many people who've um, interacted with the healthcare system for their entire lives and never had a healthcare professional stop and ask them, can you tell me about the experiences that you've had in the healthcare system? Have you felt like people listen to you? And if you leave this rounds and you're like, sometimes they ask you, what is the practice change that I'm going to be having as a result of listening to this grand rounds? And the only change that you make is I'm going to incorporate one additional question into my first encounters, into my intakes. One, you will be functioning as a more culturally competent or culturally humble clinician. And you have to create your own language to be able to comfortably probe this. For some, depending on our identities and the level of comfort that we've had exploring our own personal identity, this activates us so much that we need like extra deodorant because we can't even ask the question. And so we make it awkward for the patient, like, oh, at this point in our engagement, I'm so sorry, but I'm going to ask you a question about culture. And if it comes off that way to the patient, they know that you have not kind of resolved and you do not have any comfort around acknowledging the power of culture. And so please create your own language. It's going to take some practice and you're going to become more and more comfortable over time because that's the competence part. It's about the repeated practice. And I'm not making assumptions. No, I heard that some states are, creating laws where police um, law enforcement are going to be arresting people who look like they don't belong here. Did you know that in the 1950s, um, we had what was called Operation Wetback? And Operation Wetback was an immigration initiative that deported over 1 million Americans to Mexico, including many, many American citizens. Happened for a period of over a period of years because assumptions were being made. And again, I'm right at the end of my time. They asked me, would you have 10 minutes at the end to take questions? Uh, and I don't have 10 minutes at the end to take questions because I want to be respectful and mindful of the time that we have. This is a very small snippet of a lot of work that we're doing, but I was grateful for the opportunity to just stop in and share some of this with you. And I'd be very happy to do more of this with you or your teams in the future. So I'll pause here. So there's 1 minute. Juliet, I didn't have 10 minutes. I'm sorry.
Here's a
You have to
question.
come back to do part two.
Part two would be
There is a
great.
question. I'll take one question.
I got a
and
question.
I recognize some people have to hop
Okay.
off, but I'm happy to answer the question that's there.
Well, first of all, great presentation, Roger. Really enjoyed it. And this is such an important topic, and you really presented in a way that I think was provocative and got people really thinking. So wonderful on that. But I wanted to tie this back to the point you made earlier about access to care. I mean, and presumably that's related to disparities in outcomes, of course. But it seems to me you've posed for us a hypothesis that if we all as individuals become more culturally humble and competent, and with every encounter with the patients we do see, that over time that access is going to increase. So it seems like it could be transformational to a system, but it really depends upon individual transformation first. How do you connect?
Absolutely. Absolutely. And at the heart of cultural humility, it starts with me. And it starts with me asking questions when we create plans, asking the questions for whom. And so when we have wonderful initiatives, I want to know, well, for whom? who's going to benefit. When we build something, when we set something up, I'm always asking for whom. And the thing is, when we don't reflect on our identities, um, one of the slides that I showed you earlier, when it actually looked like uh, things were improving for both Black and for white people in Florida, but not so much for Hispanic Latinos, it's because sometimes we implement plans that with the idea that, like rising tides going to support all the boats. But when we have structural inequities, the rising tides meaning that everyone is doing better, but the disparities remain in place. And to me, that's unacceptable. And so I'm asking for whom. Yeah. So again, I want to be very respectful. I would like to thank you all for being willing to share, for being so kind as to use the chat. And again, I'll be happy to continue some of these kinds of conversations in the future. So thank you all.
Thank you, Roger. We appreciate you. And obviously everyone very much enjoyed our time together, and we hope to bring you back soon.
Okay. My pleasure. Take care, everyone.